Welcome to the deep dive. Today, we're really getting into the male reproductive system.
That's right, focusing on how it works normally and, some common issues.
And we're doing this with you, the learner, in mind. We've got some great source material here. Looks like chapter excerpts, mostly.
Yeah, covering physiology, risk factors, how disorders happen, signs, symptoms, diagnosis, treatments, the whole package.
There's even a master cheat sheet in there, which sounds useful.
Definitely a good summary.
So our mission today is basically to pull out the really essential stuff, connect the dots for you, and build a solid understanding without, getting totally bogged down in medical jargon.
Exactly. It's about giving you a clear framework, not a medical degree, just empowering knowledge for you or people you care about.
Okay, great. So let's kick things off with the basics. Normal male reproductive physiology. What are the main parts and what's their job?
Well, the core players are the testes. They've got two really big jobs, making sperm for reproduction and producing testosterone, the main male hormone.
Okay, testes, sperm, and testosterone. Got it. What's next?
Then you have the epididymis. It's like this tightly coiled tube right behind each testicle. That's where the sperm actually mature and hang out until they're needed.
Mature and stored. Makes sense. And transport.
That's the vas deferens. It's the duct that carries the mature sperm away from the epididymis up towards the ejaculatory ducts.
And I see the seminal vesicles and prostate gland mentioned here too. They're involved in.
Absolutely critical. They produce the seminal fluid. This fluid mixes with the sperm that makes semen, and it gives the sperm nourishment and helps them swim, basically.
Ah, so it's the liquid part of semen.
Exactly.
Yeah.
And finally, the penis is the delivery system, for intercourse.
Right. So quite a coordinated system. How is it all controlled? Is there like a command center?
Yeah, there's a neat hormonal pathway. It really starts in the brain. The hypothalamus releases something called gonadotropin-releasing hormone, GnRH.
GnRH from the hypothalamus.
Okay. Think of that as the first go signal. It travels, well, the very short distance, to the pituitary gland, also in the brain.
Pituitary, right.
And that tells the pituitary to release two other key hormones, luteinizing hormone LH and follicle-stimulating hormone FSH.
LH and FSH, what do they do specifically?
LH mainly tells the testes, hey, make more testosterone. And FSH is the main driver for spermatogenesis. That's the actual process of producing sperm.
Okay, so hypothalamus talks to pituitary, pituitary talks to testes using LH for testosterone and FSH for sperm. It's quite a cascade.
It is, yeah. A finely tuned system.
Which means, I guess, that things can disrupt it. What kind of things increase the risk of problems in this system? What are the common risk factors?
Well, several things. Aging is a big one. As men get older, the prostate often enlarges, and testosterone levels tend to dip naturally.
Okay, aging. What else?
Infections.
Yeah.
Especially STIs, sexually transmitted infections. They can cause things like prostatitis, that's inflammation of the prostate, or epididymitis, inflammation of the epididymis.
Infections.
Trauma, like a direct injury to the testicles, is another obvious risk. Then there are congenital things, like cryptorchidism. That's when a testicle doesn't drop down properly before birth.
Right, things you're born with.
Exactly. And lifestyle definitely plays a role. Smoking, obesity, drinking too much alcohol, all those can have a negative impact. And sometimes it's just an underlying hormonal imbalance itself.
So it's a mix. Stuff we can't control, like age and maybe some genetic predispositions, but also lifestyle choices that, might make a difference.
That's a good way to put it.
Okay, let's look at how these factors actually show up as specific conditions, starting with BPH, benign prostatic hyperplasia. What's going on there mechanically?
So with BPH, the prostate gland, remember, it sits around the urethra, the tube carrying urine out. It just gets bigger. It enlarges.
Okay.
And that enlargement squeezes the urethra. So it makes it harder for urine to get out, which can cause trouble emptying the bladder, urinary retention, things like that.
Right, pressure on the plumbing. Now, how is that different from prostate cancer?
That's a really important distinction. BPH is benign, meaning not cancerous. Prostate cancer is a malignant growth cancerous cells growing inside the prostate.
Malignant, okay.
And while we don't know every single cause, we do know it's often influenced by hormones, especially androgens like testosterone. That's why hormone therapy is often used in treatment.
So hormones play a role in the cancer too, and you mentioned screening is important.
Hugely important, because early prostate cancer often has no symptoms. You can be silent. So screening helps catch it early, when it's potentially much more treatable. The cheat sheet highlights this difference. BPH usually has urinary symptoms, early cancer often doesn't.
That's a key takeaway. Two prostate issues, very different. Okay, let's switch gears completely. Testicular torsion Sounds urgent.
It is extremely urgent, yeah. What happens is the spermatic cord, that's the structure that suspends the testicle and contains its blood supply, it twists.
Twist? Yeah.
Yeah. And that twisting cuts off the blood flow to the testicle. That causes ischemia, lack of oxygen, and the tissue can start to die very quickly. It's a true medical emergency, needs immediate surgery.
Definitely something not to ignore. Okay. What about epididymitis and orchitis? They sound similar.
They are related, yeah. Both involve inflammation of the scrotum. Epididymitis is inflammation of the epididymis, that tube where sperm mature. It's often caused by bacteria, sometimes from an STI.
Okay. Epididymis inflammation, often bacterial.
Yeah.
And orchitis.
Orchitis is inflammation of the testicle itself. This one is often, viral mumps is a classic cause, though less common now with vaccines.
So same area, different specific structure inflamed, often different causes, bacterial versus viral sometime?
Pretty much, yeah.
Right. Now, a really common concern, erectile dysfunction, ED. What's the mechanism there? Is it just one thing?
Oh, definitely not just one thing. ED is basically the consistent inability to get or keep an erection that's firm enough for, satisfactory sex. But the reasons can be really varied. It could be vascular problems with blood flow into the penis. It could be neurological nerve signals aren't getting through right. Hormonal imbalances can cause it. And importantly, psychological factors too. Stress, anxiety, depression.
So quite complex.
Very. And often, ED can actually be a warning sign for some other underlying health problem, like heart disease or diabetes, that needs looking into. The mind-body connection is strong here, too. Psychological stuff can definitely impact the physical function.
Good point. It's not always just plumbing, as you said. Okay, last one on the mechanism list. Hypogonadism. What defines that?
Hypogonadism is fundamentally about decreased testosterone production by the testes. Low T, basically.
Low T. And the consequences.
Well, since testosterone is so key, low levels can lead to issues like infertility, because it affects sperm production, and sexual dysfunction, like low libido, or even contributing to ED.
Okay, that gives us a good handle on how these things happen. Now, let's talk about spotting them. What are the signs and symptoms people should be aware of? Let's go back to BPH.
Right, BPH symptoms are mostly urinary. Think peeing more often, especially at night. Feeling like you really have to go, like right now, urgency. A weak or dribbling stream, trouble getting started, that's called hesitancy, and feeling like you haven't quite emptied your bladder afterwards.
Okay, all urinary changes. And prostate cancer. You said early stage is often silent.
Correct. Often no symptoms early on. But if it advances, the symptoms can actually look a lot like BPH, the urinary frequency, weak stream, etc.
That overlap could be confusing.
It can. But sometimes in later stages of cancer, you might see more alarming signs like blood in the urine hematuria or bone pain if the cancer is spread.
Blood or bone pain, definitely red flags. Does the way the urinary symptoms feel ever give a clue?
Not reliably enough to distinguish BPH from early cancer, unfortunately. The symptoms can be identical. That's why relying on symptoms alone is risky. Screening is key precisely because early cancer is often silent.
Really drives home the screening point. Okay, testicular torsion, what would someone actually feel?
It's usually sudden, really severe pain in the scrotum, like out of nowhere, intense pain.
Sudden and severe.
Yeah. And often there's swelling pretty quickly.
Yeah.
And the affected testicle might look like it's riding higher up than the other one. That's a classic sign. If that happens, straight to the ER, no delay.
High riding testicles, severe pain, swelling. Got it. Emergency room. Now, epididymitis and orchitis.
Since they're both inflammation down there, symptoms overlap again. Usually scrotal pain and swelling are the main things. And maybe a fever, especially if it's an infection causing it.
Pain, swelling, maybe fever. Okay.
Yeah.
And ED, the signs seem pretty obvious.
Yes. I mean, the definition is the sign, really. The ongoing difficulty getting or keeping an erection sufficient for intercourse.
Straightforward enough. Lastly, hypogonadism, the low T condition. What might signal that?
It can be a bit more subtle sometimes. Things like persistent fatigue that doesn't seem to have another cause, a noticeable drop in sex drive, your libido, and problems with fertility can also be a sign.
Fatigue, low libido, fertility issues. Okay, so someone notices some of these symptoms. What happens next? How do doctors figure out what's actually going on? What are the tests?
Well, it usually starts with a good history and a physical exam. That often includes a digital rectal exam, the DRE.
The DRE.
Yeah, where the provider feels the prostate through the rectal wall to check its size, shape, consistency, look for any nodules or lumps.
Okay. And blood tests.
Definitely. The PSA test, prostate-specific antigen. It's a blood test used mainly for prostate cancer screening. But it's important to know, an elevated PSA doesn't automatically mean cancer. Other things like BPH or infection can raise it too.
So PSA is a clue, not a definitive answer.
Exactly. Then urinalysis and urine cultures are really useful to check for infection, especially if there are urinary symptoms. Rule out a UTI.
Makes sense. What about imaging for things in the scrotum?
Scrotal ultrasound is the go-to there. It uses sound waves, totally painless, creates pictures of the testes, epididymis, checks blood flow, crucial for diagnosing torsion, finding masses, confirming epididymitis.
Ultrasound for scrotal issues and for suspected low T?
Simple blood test to measure testosterone levels, usually done in the morning when levels are typically highest.
Okay. And if cancer is suspected, either prostate or testicular?
Then, a biopsy is usually needed for a definitive diagnosis, taking a small tissue sample to examine under a microscope. That's how you confirm cancer.
Biopsy for cancer confirmation. Anything else?
Oh, yes. If epididymitis is suspected, especially in younger, sexually active men, screening for STIs is really important because that's a common cause. You need to identify and treat the specific bug.
Right. Tailored testing. So quite a range of diagnostic tools. Now, the crucial part, treatment. Once you have a diagnosis, what are the options? Let's circle back to BPH again.
Okay, BPH treatments often starts with medication. There are alpha blockers like tamsulosin, brand name Flomax, maybe people know. They relax the muscles around the prostate and bladder neck, making it easier to pee.
Muscle relaxers, basically.
Yeah. Then there are 5-alpha reductase inhibitors, or 5-ARIs. Finasteride is an example. These actually work to shrink the prostate itself over time.
Shrinking the prostate takes longer.
Yes, takes months usually to see the full effect.
Mhm.
And if meds aren't enough, or for severe blockage, there's surgery. The most common is therapy, transurethral resection of the prostate. They go in through the urethra and trim away excess prostate tissue.
TURP surgery. Okay, now for prostate cancer treatments.
Highly dependent on the stage of the cancer, the aggressiveness, the patient's age, and health. Options range from active surveillance for very low-risk cancers.
Just watching it closely.
Exactly, to more active treatments like surgery or radical prostatectomy, removing the whole prostate, or radiation therapy, using high-energy rays to kill cancer cells. And hormone therapy, also called androgen deprivation therapy, which lowers testosterone levels to slow the cancer's growth, often used for more advanced disease or alongside radiation.
Surgery, radiation, hormone therapy, multiple options there. Testicular torsion, we said emergency surgery?
Yes. Immediate surgical detorsion, untwisting the cord to get blood flow back. That's priority 1. Then, usually in the same operation, they do an orchiopexy.
Orchiopexy.
Yeah, they stitch both testicles to the inside of the scrotum to prevent them from twisting again in the future. Because if it happens once, it can happen again or to the other side.
Ah, preventative fix. Makes sense. What about epididymitis and orchitis treatments?
If it's bacterial, which epididymitis often is, then antibiotics are key. That clear the infection. For orchitis, if it's viral like mumps, antibiotics won't help, so it's more about supportive care.
And supportive care means?
Things like rest, elevating the scrotum to help with swelling, using ice packs, and taking NSAIDs like ibuprofen for pain and inflammation, basic comfort measures while the body heals.
Okay, antibiotics for bacteria, support for viruses. Got it. Erectile dysfunction treatment.
The most well-known treatments are the PDE5 inhibitors. That's the class of drugs like sildenafil, Viagra, tadalafil, Cialis, etc.
The pills, how do they work?
They help relax blood vessels in the penis, allowing more blood to flow in when there's sexual stimulation, which helps create an erection. But it's not just pills addressing underlying causes is huge. Lifestyle changes, maybe counseling if it's psychological, treating hormonal issues if they're present.
Right, address the root cause too. And finally, hypogonadism treatment, low T.
The standard treatment is testosterone replacement therapy, TRT. The goal is just to bring testosterone levels back up into the normal range.
And how is that given?
Various ways. Injections, skin patches, gels you rub on the skin, even little pellets implanted under the skin that release testosterone slowly over months. Depends on the person, cost, preference.
Lots of options for TRT. Okay, that's a really thorough walkthrough of the treatments. Now, that master cheat sheet we mentioned earlier, how does that tie all this together?
It's basically a really concise table format for each condition: BPH, prostate cancer, torsion, epididymitis, orchitis, ED, hypogonadism. It lists the key bullet points for cause, signs, symptoms, diagnosis, and treatment.
Ah, like a quick reference guide.
Exactly. So you can quickly see, okay, BPH, cause aging hormones, symptoms, urinary frequency weak stream, diagnosis, Dreppes A, treatment, alpha blockers, 5, aristonopathy. It just lines up the key facts side by side for each one. really helps reinforce those connections we've been talking about.
Yeah, I can see how that would be useful for review. Definitely helps crystallize the main points. So, wrapping up our deep dive today, it's clear the male reproductive system is, well, complex.
Absolutely. And pretty vital to overall health.
And it's prone to quite a few different disorders. We saw how some symptoms can overlap, making, getting the right diagnosis really critical.
And we've touched on the roles of aging, infections, injuries, lifestyle, hormones, lots of contributing factors.
But also, crucially, the different ways these things are diagnosed and the range of treatments available now. It seems like awareness is key, knowing your own risk factors, paying attention to your body, and not delaying seeing a doctor if something seems off.
Couldn't agree more. Understanding these conditions, knowing the signs, and seeking timely help can make a huge difference in outcomes and just quality of life.
Absolutely. So thinking about everything we've discussed, this interplay between hormones, lifestyle, aging, and how they all impact male reproductive health, it leads to a final thought for you, the listener. What proactive steps could you perhaps consider in your own life to support your long-term well-being in this really important area? Something to think about.
Definitely food for thought.
Thanks for joining us for this deep dive.